Thank you, Chairman, and good morning, ladies and gentlemen. I am very honored, but I feel a little bit nervous because my most respecting professor, Professor Goran Hedensteiner, is here, so I'm feeling a bit nervous, but I will try my best. Okay, so as we know, everything has a bright side and a dark side. So does spontaneous breeding. And I think you are all familiar with the issues concerning the bright side of spontaneous breeding. But maybe you are not so familiar with the dark side of spontaneous breeding during mechanical ventilation. But now, accumulating evidence indicates that spontaneous breeding can also worsen the injured lung at specific situations. So today, I will review the evidence to support the harm of spontaneous breeding, and also I would like to discuss when and how spontaneous breeding can be injurious during mechanical ventilation. So let me start my presentation by giving you a clinical evidence to support the harm of spontaneous breeding during mechanical ventilation. So this is one of the old case reports to show that preventing strong effort improved oxygenation in ARDS patients. So this is the oxygenation data, which is very bad when the ARDS patient preserve very strong spontaneous breathing effort during mechanical ventilation. But after preventing strong effort by the induction of paralysis, as you see, the oxygenation improved dramatically in all ARDS cases. And after 20 years have passed, the first randomized clinical trial was done by a group of Dr. Papazian in 2004, which showed that preventing spontaneous effort improved oxygenation in a severe ARDS patients. In terms of inflammations, spontaneous breathing had no impact on the inflammatory cytokines in a severe ARDS patients, but preventing effort decreased inflammatory cytokines in the VAL as well as in the blood in a severe ARDS patients. And finally, in 2010, preventing spontaneous breathing effort improved survival in a severe ARDS patients. And also, another large cohort study from United States showed that, investigated the impact of early paralysis on the mortality in a severe sepsis patient, and found that patient who received neuromuscular blocking agent had a lower in-hospital mortality in a severe sepsis patients. So these are the clinical evidence to support the idea that spontaneous breathing can be injurious during mechanical ventilation. So the next, let's take a look at when spontaneous breathing can be injurious during mechanical ventilation. The first is spontaneous breathing will be injurious when the effort is uncontrollable, when the effort is very strong. So they ventilated an ARDS patient with pressure support of 5 and also PEEP 5. But the problem is that this patient had a very strong spontaneous breathing effort during mechanical ventilation, so that they could not control tidal volume and also transpulmonary pressures during mechanical ventilation. In the end, this patient had a barotrauma. So this is a quite simple but quite important case report to show that very strong effort will be harmful during mechanical ventilation in ARDS patients. And also, our animal data showed the same direction. So strong effort with increased tidal volume worsens histological lung injury. And we can prevent this by reducing the intensity of spontaneous breathing effort. The second is spontaneous breathing will be harmful when the lung injury is quite severe. So looking at the clinical data from Papazian's study, actually the beneficial effects of paralysis was confined to more severe ARDS patients. So actually there was no difference in a mortality between spontaneous breathing versus paralysis in less severe ARDS patients. And also our animal data support this idea. So in a mild ARDS, actually paralysis worsens histological lung injury, but preservation of spontaneous breathing reduced histological lung injury in a mild ARDS. But in a severe ARDS, the impact of spontaneous breathing on a lung injury was totally opposite. So in a severe ARDS, as you see, spontaneous breathing worsens histological lung injury, and we can prevent this by paralyzing the animals in a severe ARDS. So now we can say that, okay, so the impact of spontaneous breathing on a lung injury, either it's good or bad, is depending on the severity of lung injury and also the strength of spontaneous breathing effort. And it is likely that spontaneous breathing worsens with very strong, uncontrollable effort and also quite severe ARDS. So the next, I will describe 4 different mechanisms to explain the harm of spontaneous breathing during mechanical ventilation. So the first is large tidal volume and high transpulmonary pressures associated with strong spontaneous breathing effort. So when the patient has no spontaneous breathing effort, completely paralyzed during mechanical ventilation, inspiratory pressures applied to respiratory system is consumed to inflate the lung as well as chest wall. For this reason, transpulmonary pressure to distend the lung is always less than plateau pressure during paralysis. But this is not the case when your patient preserves very strong effort during mechanical ventilation in ARDS. So when the effort is preserved during mechanical ventilation, now 2 different pressures are combined to inflate the lung. The first is the positive airway pressure from the ventilator. The second is negative pleural pressure generated by diaphragmatic contraction. So imagine when the strong effort is added to an already high plateau pressure due to severe ARDS, now the resultant transpulmonary pressure will be injuriously high, so that tidal volume will also injuriously large. The next is a quite inhomogeneous ventilation pattern observed in a severe ARDS. Generally speaking, in the normal healthy lung, distending pressure applied to local pleural, either it's positive or the negative, is transmitted immediately and uniformly to all over the lung surface, creating a fairly uniform increase in transpulmonary pressure. This uniform distribution of forces is termed as fluid-like behavior, so that in the normal healthy lung, spontaneous breathing always can achieve quite homogeneous ventilation. But when the lung is injured very badly, injured lung does not present fluid-like behavior anymore, so that the distribution of forces is not quite inhomogeneous in severe ARDS. So when your patients preserve strong effort during mechanical ventilation, negative change in a pleural pressure generated by diaphragmatic contraction is not transmitted to the rest of the lung, but rather concentrated in the dependent part of the lung, where the pressure first generated, increasing transpulmonary pressure regionally in the dependent part of the lung, causing a quite heterogeneous ventilation pattern in a severe ARDS. And we call this heterogeneous ventilation pattern the Pendeloft. And the next, I will show you how Pendeloft look like using the EIT. So the first, this is completely paralyzed, so no Pendeloft, paralysis. As you see, inflation, deflation, inflation, deflation. So inflation and deflation occurs simultaneously all over the lung field during paralysis. But when the effort is preserved during mechanical ventilation, the ventilation pattern is totally different. I mean, quite inhomogeneous, out of phase. So let's take a look at this. So when the patient starts to breathe now, and now, okay? When the patient starts to breathe, the first gas is going to dependent part of the lung. It's because spontaneous breathing increases transpulmonary pressure regionally at the dependent part of the lung because of losing fluid-like behavior. And then the gas can be distributed all over the lung field at the end of inspiration. So this is the Penderoft. And then we also analyzed the local air movement at the different lung regions during paralysis versus effort. So from top to bottom, airway pressure, esophageal pressure, and the third one is local air movement in non-dependent area. The bottom is local air movement at the dependent part of the lung. So the first is paralysis. When to start inspiration, look at non-dependent and dependent. Both regions inflate simultaneously and deflate simultaneously, which makes sense. This is just as we saw in the previous slide using dynamic EIT images, right? But when your patient preserves strong effort during a mechanical ventilation, we observe two key differences. The first, in the initial stage of the breath, spontaneous breathing causes inflation of dependent part of the lung, which magnitude is almost twice than during muscle paralysis, despite with the same global tidal volume. The second is, this early inflation of dependent lung is accompanied by simultaneous deflation of non-dependent area. So this suggests that the movement of air from non-dependent to dependent during diaphragmatic contraction. That's why we call this heterogeneous ventilation pattern the Penderoft. And also, the local lung stretch of dependent lung area caused by spontaneous breathing is actually equivalent to data applied by tidal volume of 15 ml per kilogram during muscle paralysis, so that we can say, okay, Penderoft is an injurious inflation pattern to cause local bore trauma at the dependent part of the lung. And we cannot prevent this by limiting global tidal volume. And also, Penderoft causes not only local bore trauma, but also a huge tidal recruitment at the entire dependent part of the lung. And we found this by using dynamic CAT scan images. So look at the dependent. So at the end expiration, dependent lung is now colored gray. Gray means collapsed. So at the end expiration, dependent lung is extensively collapsed. But at the end inspiration, dependent lung previously collapsed but is now aerated. So this is tidal recruitment. This is cyclic collapse. And as we know, the tidal recruitment is one of the important mechanisms for the ventilator-induced lung injury. So the Penderoft causes not only local bore trauma, but also a huge tidal recruitment at the entire dependent part of the lung, especially when you applied inadequately low PEEP. And this ventilation pattern is totally different from muscle paralysis. So I will show you how different the ventilation pattern is by using these images. So this was recorded during paralysis in a severe ARDS. Look at the dependent. So now, as you see, there is almost no changes in a lung aeration during respiratory cycles, which means that most of ventilation, most of tidal volume is now shifted in the non-dependent area. To support this, now the tidal recruitment is limited only in the intermediate zone during paralysis, right? And also, I would like to emphasize that injury occurs where the gas goes. So let's take a look at the distribution of inflammation by using FDG PET techniques. So the first, this was obtained during muscle paralysis in a severe ARDS. So as you see, now the inflammation predominantly occurs in the non-dependent area, where typically receives most of ventilation during muscle paralysis, right? And this findings is compatible with what Dr. Giacomo Verani found in his previous paper. So Dr. Giacomo Verani found that inflammation predominantly occurred in the non-dependent aerated lung region, but not dependent collapsed area. So he found this by using the same techniques in the humans. But when the strong effort is preserved in a severe ARDS, look at this pattern. So now the distribution of inflammation is totally different. So strong effort increases inflammation extensively. So now inflammation occurs not only in the non-dependent area, but also it expands to dependent part of the lung. It's because Pendeloft causes local ball trauma and also a huge tidal recruitment at the entire dependent part of the lung. The next is increased perfusion associated with strong effort. So first, during positive pressure ventilation, usually pulmonary vessel is compressed because surrounding pressure, which is the pleural pressure, is positive, it's high. But when the patient preserves strong effort, now the surrounding pressure is lower than during muscle paralysis. So the negative pleural pressure distends the pulmonary vessel, increases pulmonary perfusion. And please note, in the presence of lung injury, permeability is always increased so that lung edema is also likely to be increased. So the next is asynchrony. When the patient preserves spontaneous breathing during mechanical ventilation, patients always have a risk to be suffered from asynchrony. And interestingly, recent paper found that patients who had more asynchrony had a higher hospital mortality. And before finishing my talk, I would like to introduce one very interesting concept, which is patients hurt themselves by their spontaneous breathing, which was written by Dr. Brocha and also Professor Antonio Pesenti here as a chairman. And I strongly suggest that you should read this very interesting perspective on spontaneous breathing. So the first, initial lung injury occurs like pneumonia or the trauma and so on, and it causes capillary leak, increases lung edema. Increased lung edema, of course, worsens oxygenation and worsens compliance in a patient. And worsens oxygenation and compliance absolutely increases respiratory drives of the patients, right? So severe lung injury and strong effort, they are closely related with each other, and both work together to worsen already injured lung with several mechanisms that I explained today. So this is what we call vicious cycle of spontaneous breathing, and we have to stop this vicious cycle of spontaneous breathing by decreasing strong effort, for instance, by using neuromuscular blocking agent fully or partially, and also by improving gas exchange and lung mechanics with lung recruitment. So I believe that this is the strategy to decrease the harm of spontaneous breathing, especially when the patient has very strong effort and the lung injury is quite severe. And the concept of my talk is also summarized with this perspective, which was just published in a Blue Journal. And I would like to stress that this perspective was written with my previous all mentors. So the first is Professor Fujino, the second is Professor Amato, and the third is Professor Kavanagh. And then here I would like to say that I am very, very grateful for their excellent mentorship. In the end of my talk, I would like to share some pictures with you. So here is Professor Fujino. He's my first mentor when I started the research on the spontaneous breathing during mechanical ventilation at the Osaka University. And then they are my colleagues working together in the ICU at the Osaka University. Absolutely, they are very excellent team. And the second is my second mentor, who is Professor Marcelo Amato. And I was in Brazil when I was a postgraduate student. And there we found a Pendeloft by using the EIT. So this is one of my unforgettable moment in my life. And the third is Professor Brian Kavanagh. So he's my current supervisor at the University of Toronto. And he's super excellent mentor in my life. So as you can imagine, the perspective on the spontaneous breathing means a lot to me. So if you're interested in the spontaneous breathing during mechanical ventilation, please also take a look at our perspective on spontaneous breathing. Thank you very much. Thank you for your kind attention.